So, Ngurri Nungi, everyone, and Nungi to the race grand rounds, a time for the Riverland Mallee Coorong Local Health Network to hear from experts from around the world and from within our own health service so that we can learn together and take those learnings into improving the care that we provide for our communities. It's a great opportunity for us, and I thank everyone who's part of this for the privilege it is to be part of an organisation that is wanting to improve every day. Today we're very privileged to have as our guest Sharon Frahn, who has been instrumental in establishing the single employer model, or the SEM model, something that many of you will have heard of but may not exactly know what it means, particularly what it means in terms of the way that we can support trainee medical officers to have some certainty about their future and to have that opportunity to plan and to get the benefits of being part of an organisation such as RMC. So welcome, Sharon. Your work in many areas in our LHN has been outstanding, and I know you've been nominated for awards within the LHN a number of times because of the impact that you have as being a finisher completer as well as an innovator. So we're very glad to have you, and over to you. Thank you.
Thanks, Professor. Thanks everyone for joining today. My presentation is probably not as exciting as last presentation. That was amazing, but thanks for coming anyway today. So I'm talking about the single employer model, or what we call the SEM model. The journey we've had in our LHN over the last couple of years. It's a medical workforce model for trainee medical officers. So we'll go through some points to show how that's improving our medical workforce service. I'd like to acknowledge traditional custodians whose ancestral lands and waters we're meeting on here today, in particular the Coorong people where I'm sitting today. Pay respect to the elders past, present and future, and acknowledge deep feelings of attachment and relationship of Aboriginal people to country. Everybody online obviously knows all about our region, and the next slide is quite obviously as well the data well known, but I just wanted to point out that prior to 2020 we had 95% of all of our medical services provided in our hospitals were run by local generalists. So that's above and beyond their private general practice work. Now we've got over 100 full-time equivalent FTEs, salaried medical staff across the LHN. This reduces that load on our local GPs, because many in some cases would start on a ward round at 6:30 or earlier in the morning. They'd go off to their clinic for a full day of clinic appointments, and then they'd come back and do another ward round and go on till late in the evening. So that didn't really equate to a very attractive role, attracting more rural generalists into the country, overworking our poor rural GPs. And it certainly had that effect across the country in dwindling rural generalist numbers. So this supports the salaried medical model that we've implemented at Riverland General Hospital initially. The single employment model known as SEM trial is just the one tool that we use in our little toolkit in increasing and retaining that medical workforce across the local health network. So we've implemented this, the RACE model, it's a medical training pathway initially in 2022. We had 5 interns in our initial cohort. Now, the SEM trial commenced late in 2023. Basically, the SEM is that it's a Commonwealth initiative against the Medicare legislation that we can use as an exemption, so we can allow a state health employee to bill Medicare whilst they're working in private medical practice. And we'll go through the many positive elements of that throughout the slides. So basically, we're supporting the employment of a doctor in our LHN from the new grad period, from internship right through to their fellowship, graduating as a GP. But usually when they do their registrar training in general practice, the doctor have to leave the public sector to undertake certain points of their training, and they'd be lost to the health service then, and quite often to a rural area. They'd also lose their entitlements like their sick leave, maternity leave, their professional development entitlements, etc. Never often to return to a hospital system or the area. A lot were lost back to the city. The SEM exemption basically enables us to remain the employer and them to work across both public and private practice. Lots of other advantages for that setting of both across public and private. It also gives the organisation and the doctor a stable employment model. So we've also received local and national interest on the success of our model. We employ the medical officer for the length of their training period, usually over the 5 years. We've provided a tailored and coordinated pathway for doctors who want to become a rural generalist in our area during that training pathway. And there's lots of points there. So, you know, they get to do all their required training and they don't lose any of those entitlements, which makes it a bit more easier for the doctor. So there's a lot of accreditation requirements, as you would know, for designing education pathways. The rotation design we had, the medical education unit's been really instrumental in being able to develop lots of experiences to expand the training opportunities for the trainee medical officers. And that's attributed in part to the SEM and also in part to the great collaborative relationships with our local rural generalist partners. All of that also contributes to the retention of staff. The 5-year tracks we provide to our new grad are actually unique to our LHN. For new grad doctors, there's no other area in Australia that would provide this. It's a great innovation and incentive for our new grads to come to the area. This is basically a traditional way of achieving a GP qualification for a new grad. So after the university studies, they'd come out, they'd apply for an internship. They get to nominate their 5 preferenced places for that in a centralised process. They don't always get their first or second or third choice, but essentially shows there's at least 4 different job interviews they'd have to undertake in the 5 years across that training pathway in both public and private practice. It's quite a competitive market in the training medical officer recruitment space, so there's no guarantee of placement either. There's no guarantee of employment in the public sector either. This SEM exemption basically helps us to provide a streamlined process for them. So they apply for internship, we provide that 5-year contract, and they get to just settle in, stay and concentrate on their training pathway. The majority of our doctors too have also appreciated that 5-year contract, because it's not, whilst we don't bind them to it, like they can resign at any time. It actually provides them an opportunity to go out and get a house loan, which the previous way of employment didn't support at all. So we've actually had the majority of our staff buy their own homes and settle in the area. We've just entered our fourth year of the SEM. We actually currently employ 42 trainee medical officers in the RACE program overall. We've currently got 8 interns, 4 RMOs, 15 GP Reg, and 5 people doing an advanced rural stream training, specialist training, sorry. And currently we've got 10 doctors doing a 19-2 SEM rotation out of the 42. There's 5 practices involved across Riverland and the Murray Bridge and Mannum areas. And we've got the majority of interns, well, all the interns are based at Riverland General Hospital due to the salaried medical model and the supervision requirements that we have for internship. And all the other sites are staffed by contracted rural generalists through the SA-GP agreement. Some of the key outcomes to date are nearly 90% retention of the doctors through the program. That's across the RACE program, including the SEM doctors. We've got 94% of those doctors still on country. So some have taken private contracts with clinics, but they're still on out servicing our community members. So the growth of 42 trainee medical officers is basically since 2021. So we had 0 trainee medical officers employed by our LHN in 2021. Now we've got 42. It's a great achievement. We've had a locum cost reduction and increase in funded activity, which equates to generated income. So these are the fundamental elements to our success. The general practice communication and collaboration has been a key for us. We're so grateful and privileged to have those people involved in our RACE program overall, and the SEM especially. Without them, we couldn't do what we do. It's amazing. It's an innovative way to do public health service, but it's the private practices that have really made sure this is as successful as it is. We also have our heads of department in the public sector, and they've been on board and in regular communication as well. We have regular catch-ups with our GPs, practice managers, etc. We have hopefully an easy access to those people as well for our finances and funding. Sorry, I'll just go back. Yeah, so many collaborative relationships have been formed with the core really vision of increasing the medical staff across the region. And just the last point, I think the culture from SA Health admin staff is very important to maintaining those collaborative relationships. Some of the positives are being done at the moment. There's lots of ongoing review and improvement strategies that we're looking at. We're also looking at assisting others from across Australia with the implementation of their trials. There's been a national rollout of trials recently about to commence. We're actually, we as in Professor Worley, myself, Dr. Fegan, Dr. Wayne Champion, and our medical education officer, Susan Zierscher, attending a national SEM forum in Queensland next week. We're actually providing a presentation on our SEM trial, as we're the second people in Australia to actually undertake it, but we were the only people that were extending it out further than the 2 years from the initial rollout. Lots of things happening, and yeah, aiming to publish, etc. as well soon. more positive results have been based on all of these you see here. These are just some of the reasons that it's been successful. But yes, again, I'd say the collaboration of the private general practice and public health services has been instrumental to the success. Our SEM participants have also been part of amazing things across the LHN, including research and implementation of and design of service innovations such as the fracture clinic. And so that's been a really exciting offshoot of that as well. And hopefully this has shown the innovative approach that the Medical Services Unit has towards operational implementation and support of building our own locally grown and trained medical workforce. Thanks.
Sharon, thank you so much for that really comprehensive presentation. But while people get their questions ready, I've got a couple of questions for you just to get things started. So is it possible for TMOs to have one foot in each camp? Is it possible for them to be partly a SEM employee and partly a private practitioner employed in the private practice?
Absolutely. So that's the whole philosophy of race overall, I guess, is to have that flexibility approach and have a choice for the employees. So whilst many other areas across Australia are only doing one or the other, not providing a choice, we've actually provided a choice and worked out ways we can do both. Whatever suits the practice.
That sounds like more work for you and your team in negotiating a person who's working in general practice and partly employed by us, partly employed by the practice. But that is possible.
It is, yes, but it is possible.
Do you have any suggestions or understanding of why different TMOs would choose the private option or the SEM option within our LHN?
Sure. Couple of things instantly come to mind would be some people would choose the SEM option to remain in government employment, so they retain things like their maternity leave entitlements, etc., because there is a time frame for that to be eligible to apply. So if I came out as an intern, I could work for 18 months for the government. But if I left to work in private practice to do my registrar year, I would lose that entitlement. I'd have to then come back and work for 2 years to be able to be receive maternity leave, for example. So that's one reason. The other is sometimes the private practice can provide additional funding in some situations, not all, or flexibility in working hours.
So there are potential positives in each system that our TMOs can essentially get the best of both worlds if they want.
Yeah, so generally our TMOs will have a conversation with both sides, with SA Health, with the Medical Education Unit, led by Dr. Esk, and with the clinic that they're looking at applying to do a SEM through in their rotation and see which suits them the best.
So thanks for that. So one of the other questions I have is, obviously this has been very helpful for our medical workforce. We have an allied health workforce and a nursing workforce that also are under strain and need to develop strategies for improvement and sustainability. What principles do you think could be applied from what we've learnt in the SEM approach? What could be applied to nursing or to allied health workforce development?
I think the culture developing that service. So
So you just froze on my screen
I'll
for a
just
bit
see
there,
I dropped
Sharon.
out.
Yeah.
Sorry.
So start again. That's great.
Yeah, just a
While other
culture
people are
change on
thinking of
that.
their questions.
Yeah, just a culture change on how we approach the workforce development. What I mean by that is not always thinking how it's always been done, but thinking outside the box, talking to the people you want to employ, the type of people you want to come and work for you. What hours do they want? Do they want to work different length shifts? Do they want different days? Do they want different types of employment? Do they only want to work certain shifts or certain hours? Whilst you have to work towards enterprise bargaining agreements, etc., there is a lot of flexibility we can provide still, um, with a little bit of, conversations first and not just doing what we've always done. The next is, I guess, doing the background research on how you can make it as easy as possible for the people you want to employ, how you want to make the training program or the new graduate program as smooth and as enjoyable. What are the experiences they want to have while they're doing it? What are the training that they are interested in? Not just doing the same old rotations. We have many, many new rotations we've developed because of a TMO has come and said, I'm really interested in palliative care. We have now just had an approved palliative care advanced skill rotation developed that we've put a TMO in Adelaide for 6 months and here for 6 months. But we've had to go out and find, somewhere to put them. We've rented a house. We've done all that background organising to make sure that those things are available for those people, because that essentially also retains your staff. It's not about just attracting staff, it's about retaining them as well. You sort of have to think of the whole picture at once.
You raised an interesting point there, Sharon, in terms of accommodation. So if you look at many of the recruitment and retention strategies across rural Australia, the first thing that's mentioned is free accommodation or that sort of thing. Whereas what I heard you saying there was that we'll provide you with accommodation back in the city when you need it, but not locally. Is that the case?
We provide a initial accommodation attraction to our new grads who request it. So as an initial attraction, but that's only a short period of time, just to help them settle so they can find their own or take over the lease, etc. So that takes a lot of organising as well. But yeah, we do offer that, but not an ongoing assistance, because we've got those other strategies in place, such as providing a 5-year contract so they can actually apply for a home loan, for example. Whereas before they couldn't do that because no bank would give them the money, even though they're a newly graduated doctor. They don't have that proof of ongoing contract to be able to be provided a loan.
My last question to you is it's been going just over 3 years now into the 4th year. What's your vision for what this may look like, say, in 5 years' time, if it's been as successful as you want it to be? So what would it look like in another 5 years?
Yep. So this first 5 years is obviously a trial. Going forward, if we're successful in ongoing SEM exemption, I'd love to see it being just an integral part of our recruitment strategy to say, this is available, you can do this or this, and this is the reasons why. It's like basically have an information document for our university information sessions that we can go, actually, if you come to our LHN, you can become integrated into our community right from the get-go. And I'd love to see it more widely spread out across the LHN. So currently we're obviously still in the Riverland and in Mannum and Murray Bridge. So to go across Mallee out to, you know, Meningie, Taylor, etc., to be able to spread that a bit wider and share the love, so to speak.
It's quite a vision, and I guess there is the opportunity then for people who've been employed as trainees to go on with employment in the LHN as consultants. What sort of opportunities do you think there are there for trainees?
So ongoing, once they've gone through that 5-year training pathway, they've come out as a consultant, real generalist, general practitioner. They can then have part-time contracts with us in our emergency departments. We've got people that are interested in internal medicine. So on the ward, for example, at Berry, they could be a part-time in a clinic. And we've got quite a number who have actually had interest in them from practice partners as well, to become partners within practices. So there's that future proofing of their workforce as well. So that's really good. That's what it's about. It's building that clinical workforce in the medical space and future proofing the services for the community, and making the other real important element is making the training as great as we can and extensive as we can, because we want great clinicians, which we're getting a lot of. We've got 42 amazing clinicians coming through. So,
and I guess there are a couple of places in our LHN where trainees could go on to a fully salaried career in, say, Lameroo or Pinaroo or Coorong, or that could be part of their work-life balance, and they could be in private practice somewhere else, but salaried practice in the GP clinic in those towns. Yeah, look, I get a sense of your passion and your excitement when you're thinking about the trainees, and also when you're thinking about what the future could hold for our region. So thank you so much for sharing that with us today, for outlining a lot of the detail that goes behind the scenes in what can appear quite a seamless, simple thing from the surface, a bit like the duck swimming across the pond. A lot of paddling going on underneath.
Got an amazing medical services unit team, absolutely. Yeah.
And all the best for the presentations next week in rural New South Wales, rural Queensland.
Queensland, yes.
Rural Queensland.
Pending some wind issues.
Provided the cyclone allows us in, hey?
Yeah.
That's great. Thank you all for being part of today's Grand Round. Great to see everybody getting together and to hear about the great work that's going on this time inside our LHN. We'll look forward to seeing you in a fortnight's time, Nakan, and we'll see you then. Ananingya.